Hello and welcome. UVA Speaks is a podcast of Lifetime Learning, a division of the Office of Engagement at the University of Virginia. Lifetime Learning brings the knowledge and expertise of UVA's faculty to the university's alumni, friends, and families. My name is Susan Lynch, and I am the Associate Director of Lifetime Learning at the University of Virginia's Office of Engagement. This podcast features Dr. Scott Heysell, the Thomas H. Hunter Associate Professor of International Medicine and Director of the Center for Global Health Equity at UVA Health at the University of Virginia. Dr. Heysell is an active researcher and supports partners worldwide to reduce tuberculosis-related deaths and correct factors that contribute to tuberculosis, including poverty, health system management, and chronic medical conditions such as HIV and diabetes. His research group also studies how to maximize drug efficacy to improve treatment outcomes. In this podcast, Dr. Heysell will talk with us about global health. So thank you, Doctor, for speaking with me today.
Oh, thank you, Susan. It's my pleasure.
So first, can you tell us about your background in global health?
Sure. I was an English major in college. I love narrative and understanding a story from a lot of different angles. That actually strongly considered a career in journalism. But it was volunteer experiences that were working with different communities that were marginalized from the healthcare system that really inspired me to pursue a career in health. First was working in East Tennessee and in Appalachia, and really understanding rural poverty for the first time here in our own country. And then later in college, it was actually working with people with HIV, human immunodeficiency virus, the virus that causes AIDS. But it was a time in the mid 90s that antiretroviral medicine or the treatment for HIV was suddenly making what was once a death sentence into a condition that people could live with for really a healthy remainder of their life. And so it was a really exciting time. And that inspired me, but also, got me to ask questions like, if the person is marginalized from the healthcare system, well, then, who is the marginalizer? And if someone's suffering from a lack of resources or access, well, how are those resources being prevented? Do some people's good health exist because of other people's ill health? And these were, really tough questions that I wasn't, quite as experienced in thinking about at that time. And then I went to medical school to be a rural healthcare doctor, and there's a lot of challenges and to do so in our healthcare system currently, even some disincentives to be a primary care doctor. But it was experiences there that really pushed me towards global health and my current understanding of what global health is. And the first was to participate in a public health training program, a master's of public health, where for the first time I was working with nurses and lawyers and other professionals that were tackling problems at the population level. So an example might be secondhand smoke exposure and the policies around limiting smoking, cigarette smoking within public places, and that link to cancer and lung diseases, which now we really accept as pretty commonplace, not to go into a restaurant and smell smoke. But these were professionals really working at kind of upstream drivers of health that had population level solutions. And then the other was really my first experience in health outside of the US. And I worked in a hospital on the outskirts of Hyderabad, India. And this was, again, as a medical student with sort of some basic training. I lived in an old hospital room inside sort of an unused wing of the hospital. But I befriended students and nursing and medical students. I volunteered village to village in a polio vaccine campaign, spent time at a leprosy rehabilitation center working on some of their organizational strategies. But it was really the first time that I saw, significant undernutrition, starvation, and driving conditions of health that were really rooted in class or in the Indian system in caste. And so this was just like a splash of cold water to the face, so to speak, in terms of the determinants of health that were really predetermined. And, in our US system, this might be a racialized predetermination of health. And and so I just saw a lot of similarities to to the global north, even though I was working and living in India at the time. Um, I also I had like 5 days of a febrile illness where I thought that I had cerebral malaria, typhoid, dengue, every infectious disease that I had read about. And so that even, I was hooked at that point. I was going to be a infectious disease doctor working in global health. Um, and then in residency, sort of in the internal medicine training part of my career, so having graduated from medical school, but really working for the first time caring for patients, I spent time living in two different points in my training in the same rural location in South Africa. And and this was a time when antiretroviral medicines for HIV and AIDS were being provided in a community that sort of harkened back to my college experience, almost a decade before. And this was through the really laudable initiative of George W. Bush and the President's Emergency Plan for AIDS Relief, or PEPFAR. And for the first time there, medicines were being provided that were improving outcomes for HIV. But it was tuberculosis and the conditions that drove tuberculosis there that were really causing significant health problems. And so I worked with my US based institution, a South African institution, and the University of KwaZulu-Natal, with local health departments in a way that was providing research-based care, that we were using our evidence to change policy, but doing so really with the leadership of local health stakeholders, and in a way that I hadn't been a part of previously. And so that really provided the model that I can sort of, we'll share a bit more in the rest of our discussion, I think, and what I think, already prepared to do here when I started at UVA. But what I found at UVA was really a school of medicine and an overall mission to work in the diseases of poverty, and that was something that really attracted me to the institution and has really kept us going, kept the work going. So there's a real commitment here, and I think that there are opportunities for for us to build on what already exists at UVA.
Great. Thank you so much for that background. I'm certainly glad to hear that there is a home for that kind of work here here at UVA. That's such important work, and I'm so glad to hear that our institution is a good home for that. So that's great to hear. So, to build on your background, can you define for us what is meant by the term global health? And then how does the field of global health seek to reduce health inequities here in the United States and, as you mentioned, across the world?
I think that there are some definitions of global health that are historically rooted in a worldview that implied some cardinal directionality to countries or certain parts of the world. And so an example is third world countries. And I think this is a historical term that we should no longer employ. And really, that global health in that definition focused on diseases or infections that were often described as tropical, given the location in many of the poor regions of the world near the equator. And these were determined by prior colonial impoverishing systems. And so many infectious disease researchers or clinicians that were interested in those pathogens were just by geography sort of working in global health. But in that, I would say, misplaced directionality, there's this assumption that global north would be providing solutions and expertise and resources to the global south. And then, despite some of the successes like PEPFAR that I mentioned, there was, this misplaced directionality that really further enforced the same structures that were impoverishing or creating ill health. And so, a country, for instance, that wanted to receive a World Bank loan or an International Monetary Fund loan had to adhere to certain stringent World Health Organization recommendations for how to fund and carry out health for certain diseases. When a country on their own may have had a better solution, but they lack the money, to really carry out or implement their solution. But then it created this incentive to continue to report rosier outcomes for these WHO metrics in order to continue to receive the funding. And this happened for tuberculosis, something that I'm quite familiar with, where in well-done retrospective studies now, they found that accepting an International Monetary Fund loan was actually associated with worse tuberculosis outcomes, including higher mortality. So if that's sort of, the what, we've learned, I would say that our globe also includes the United States, and it includes Charlottesville, the Bronx, Southwest Virginia. And we recognize that health here is dependent upon the health of our neighbors down the street, our children in school, our elders, and also the health of our neighbors across the border. The COVID pandemic really laid this bare. And we can also learn then reciprocally from the innovation that occurs in locations of the world where at first glance we seem to share very little. And so an example of that would be ruralness or disconnection. And so one could be disconnected even though they're living in a city of many people, or they could be disconnected due to significant geographic distances from places or people that promote health. And we learned this, for instance, in working with people living with HIV and using substances in Siberia. So prior to Russia's invasion of Ukraine, we worked for almost a decade in Irkutsk, Siberia, and a lot of the challenges there were related to disconnection. But we have mobile and digital technologies that can help to overcome those disconnected barriers and link people to health care, but also to one another in a way that supports their own health. And this is the same types of issues that we observe in rural Virginia, in parts of the urban US as it relates to HIV, but hepatitis C, substance use, the need for addictions, medicines, the needs for reproductive health access in some of our healthcare deserts that we're really seeing now. So I think a more inclusive definition of global health is one that promotes health for all with a focus on alleviating those social drivers of suffering and the power imbalances to now restore a more equitable opportunity for health.
Yeah, sort of check our biases as we're thinking about this issue. That's really good and interesting to check that whole thought about having the IMF funding not what one would expect the outcome to be, and so important to think about that and what that means.
That's right.
Very interesting.
Yeah.
Can you tell us about UVA's Global Center for Health Equity?
Yeah, absolutely. I am very enthusiastic to be part of this team that champions global health across grounds. So the Center for Global Health Equity, it's a pan-university center. So it serves all schools at UVA, the entire UVA community. And we're part of UVA Global, which is led by Ambassador Steve Mull, the Vice Provost for Global Affairs, and new Director of Global Initiatives, Tina Mangieri. And the center also works with the Center for Global Inquiry and Innovation. So that's a faculty research oriented center led by Brian Owensby. The International Studies Office, which oversees really all student mobility, so upwards of 3,000 students across the university, led by Dudley Doan. And then the Global Studies program in arts and sciences. And so this is one of the most popular majors now. The most popular track within that major is Global Public Health, and that program's led by Phoebe Chrisman. So a really complementary group of centers and initiatives at the university. But the Center for Global Health Equity primarily provides opportunity for applied work, so applied research or clinical training in a broad range of health disciplines. And we primarily work in priority partnerships is how I think we'd like to shape those relationships. So these are in locations such as Tanzania, South Africa, Uganda, Rwanda, Ghana, Nepal, India, Bangladesh, Nicaragua, Southwest Virginia. These are locations where we've had most of our recent work. And so a student would typically access these opportunities during their summer months or during times outside of the typical Charlottesville classroom. And so for the non-clinical students, for instance, recent projects have ranged from studying a wearable fabric to protect against air pollution from motorcycle taxi drivers' exposures in Kathmandu, Nepal. Um, and then, all the way to using, for instance, publicly available NASA satellite imagery to predict the best crop species and where to place crops based on average and timing of rainfall in the country of Chile. And that was also utilized by local agricultural stakeholders there. So just a range of really exciting student involvement. But these are, mentored research-based experiences really by all disciplines across the schools. And then there's medical trainees that are often in their later stages of medical or nursing school or later stages of training within those schools. And then they're working in hospitals and clinics to fill gaps locally, and they benefit tremendously from the knowledge and experience that our global partners impart. So we work really hard at Parity, trying to make sure that those projects lead to direct health benefit. And these are lessons that I learned from my mentors here, former directors of the center, for instance, Dick Garant, who dedicated a lifetime of work toward ameliorating the diseases of poverty. Becca Dillingham, the prior director who created really this center's current model to work with marginalized communities and try to dismantle some of those structures of marginalization, often just by listening first. So this is sort of a high touch center, high touch work, so to speak. Lots of relationship building, and so as we move to work forward, we really want to prioritize those partnerships where we can work collaboratively, but then also reach health metrics that we can measure from year to year. So I would just say, if anyone is interested, we would love the help and support.
Yeah, I'm always so impressed by the Pan University initiatives. There's just so much happening at the university, and working in alumni engagement, I get to work with people across all 12 schools, and so I see the great work that's being done, and to capitalize that on within these different centers, it's so important, so that there can be these sort of efficiencies of everybody working together on program on different problems. So
Absolutely.
it's really great. Wonderful to hear about the center. So thank you for that. Your research is related to infectious diseases, as we've spoken about, and that occur more commonly outside the United States. Can you tell us about your work and how it impacts people in those communities and even perhaps locally?
Yeah. So, I've mentioned that I work primarily in tuberculosis. So prior to COVID and soon to be as sort of the COVID dynamics change, tuberculosis, or TB, as I may call it, is the world's leading cause of death from a single pathogen. This is a historic pathogen. The romantic novel the poet that is suffering, as John Keats did with tuberculosis, for instance. But the conditions exist still. These are conditions of poverty that drive undernutrition, for instance, and undernutrition is just one of our most important drivers of immune deficiency. And so when we don't have enough to eat, our immune system doesn't work, and it leads to infections like tuberculosis. So I would just say, I work with the most outstanding people And I'll just provide an example. So I've been working in Tanzania for about 15 years now. And I work with Professor Stella Empagama as one of my main partners there. She's director of research at Kibongoto Infectious Diseases Hospital, which is at the foothills of Mount Kilimanjaro, a former tuberculosis sanitarium. And we have worked now on projects to improve diagnostics for people with TB. So we found that if you are accessing care at a public healthcare center in Tanzania, that there are conditions that create a significant challenge to receive what should be a fairly easy test. Someone should be able to cough in a cup, and that cup should be analyzed in the equivalent of an espresso machine, and within a couple hours should have a diagnosis of tuberculosis. But sometimes those machines don't exist. Sometimes electricity is not present. Sometimes there are uh, people working in those clinics that are not offering that sputum cup. And sometimes those results don't make it to the person in time or in the way that they need to. And so we're trying to work on certain, again, kind of upstream drivers of why it may be difficult to access that type of care. But then we've also tried to integrate care that's been previously siloed. So chronic conditions like diabetes or malnutrition that might be treated in certain parts of the healthcare system, but really predisposed to infectious diseases like tuberculosis. And how do we integrate that type of care at the health system level? Um, and then even more recently, we've moved toward randomized control trials, even focusing on mortality. And so one of the most uh, important findings is that we've found among people that are undernourished or people that have HIV, that then present to the hospital with the end stage of infection, the disordered immune system that occurs with really severe end stage infection that we call sepsis. And so people with sepsis in Tanzania and in some of our other partner sites in East Africa, the most common cause of sepsis is tuberculosis. And so this is not often thought to be a bloodstream infection or one that really causes this severe end stage disease. And it's not at all the most common or even close to that in the global north. And yet, the current standard of care is to treat with an antibiotic that treats the pathogens of the global north. And it's in part because a lot of the work has focused on other aspects of treating tuberculosis, but we think this is one where we can focus and actually improve a mortality outcome. Um, but I think the main thing to emphasize is that what Stella has done, Prof. Bagama, who is actually a visiting scholar here at UVA, and what she's really championed is the education of scientists. And so we've had collaborative projects where we've built research capacity in the form of laboratory infrastructure or other forms of brick and mortar infrastructure. But all throughout, she has really championed the education of Tanzanian scientists at various levels, from undergraduate to master's to PhD and postdoctoral scientists. And that's even where we focus now. Most recently, we have a NIH-funded training grant for Tanzanian postdoctoral scientists, mostly to focus on this intersection of undernutrition and infectious diseases. But what's interesting about that, what relates to your question, is that we have also involved our UVA trainees collaboratively along the way. And most recently, we had, as an example, a workshop in Tanzania for the Tanzanian postdoctoral scientists. It was focused on data science. And we brought faculty from UVA that are expert in data science at that new school. And we also involved our UVA trainees. And so we now, through the education and training of Tanzanian scientists, are also training our U.S. Uh, uh, young scientists and researchers that will be really carrying health related research forward in the future. And there's just numbers of examples of that, even within my own division here in the School of Medicine. People like Margaret Kosek and Josh Colston, who work in Peru, Chelsea Marie, Bill Petrie, Mami Taniyuchi, working in Bangladesh, Chris Moore in Uganda, Tanya Thomas in Tanzania, Eric Haupt, James Plattsmills. These are people that are all doing that type of work, and I think have really brought along our U.S. based trainees in a way that is underappreciated. So we still think of this sort of directionality in our training, and that we are providing some form of expertise in a part of the world outside the U.S. But we just benefit tremendously from those interactions as Americans, as UVA citizens of our university here. So I just wanted to emphasize that point as well.
Yeah, thank you. Thank you. And what a wonderful opportunity for our medical students. And finally, what are some of the future challenges to global health, and what are some of the most exciting possibilities for improvements?
Yeah, I think some of those challenges are ones that we face in a lot of other threats to our existence. Even these are existential type threats. So I like to think of health as really a lens for some of the bigger problems that we face in society, and so these are problems of authoritarianism, really anti-democratic movements that are happening in various parts of the world, and that tend to align some countries and some regions and some leaders. And then, pure conflict. So war and conflict completely disrupt healthcare systems, and do so with um, generations of impact. And so we will see that in Gaza, and we will see that in other parts of the world, in Sudan, as an example, places that we will see generations of health impact, that, as we understand health to be dependent, our health is dependent upon the health in people in those parts of the world. That will impact us globally for years to come. And the other, might be climate change. I think is something that worries us all, of course, but has so many different ways in which health is adversely impacted by climate change. And just to give one small example, so as our world warms, and the types of vectors for certain diseases that like to live in certain parts of the world change, we have mosquito-borne illness that will likely make its way into our country, where it's more common in other parts of the world. So an example is malaria. And so there is some reasonable models that suggest that we'll have malaria in the southern United States within, for instance, my lifetime. So these are concerns, and I think we should, be working toward alleviating these concerns. At the same time, I am hopeful, and the reason that I'm hopeful is that we have hopefully learned from the COVID pandemic that we are a interconnected world, and we must work towards solutions collaboratively. And I think that's where global health and the experience in global health really can provide an example for other types of leaders and other types of problems in the world. And so we, I think, by nature, are a collaborative field and a collaborative discipline. And so, as an example, we have faculty working in rural Kenya on children with disabilities, such as autism, and improving their families' health and their families' well-being, to use that term, within that community. And so these efforts are led, for instance, by Mandy Rispoli in the School of Education, Katie Quissel in Public Health Sciences, and they're approaching the the challenge in different ways with their own disciplines and own expertise. And so they're working with Kenyan partners there, and I think it's just a great example of how global health is not a biomedical field, and often these solutions are not biomedical. They can be, or they can be in part, but often require disciplines, in this case, in public health and education, that are really going to bring benefit. And then the other thing I sort of touched on a bit briefly is the use of some of our developing technologies that really can overcome barriers of disconnectedness, and then the sort of pockets of expertise, pockets of resources that have been held by certain countries, often wealthy countries, or certain regions, or certain institutions. I think may be less likely to be held and more likely to be shared in the future with the use of technologies such as artificial intelligence or mobile or digital health. And so, if one can have, in their hand, access to the expertise of the world of health in a way that they couldn't, even 10 years ago, I think that there's, tremendous potential that this could be used for good. An example, I mentioned sort of the use of mobile technologies in Siberia that's now being applied here in the U.S. But in my work in tuberculosis and undernutrition, one can use artificial intelligence or AI to read a chest X-ray and use that information to compare to thousands upon thousands of chest X-rays that then have been scored for the likelihood of tuberculosis. And our ability to actually take it in X-ray image has improved, and one can do so mobilely in a very rural community without the need for healthcare infrastructure, and then can be scored and read by a machine, and that provides a likelihood of tuberculosis that I think can be implemented in a way that's going to provide more immediate care and treatment to that person living in a rural area. And similarly, there are programs for understanding undernutrition or food. So you can take a photo of a meal and figure out exactly what the caloric intake and distribution of fats and proteins and everything else that are in that meal. And we're getting very close to really understanding the microbiome, all of those bacteria and other germs that we live with and help to control a lot of things that happen in our body. So there might be a time in the near future where we're pairing a photographic image of a meal with a point of care test to understand someone's gastrointestinal microbiome in a way that we're really tailoring solutions to improve undernutrition with the understanding of all these drivers of undernutrition. So I'm hopeful, as you can tell, and I think at the same time we need to assure that the technology that we have is really going to be used in a democratic and ultimately equitable way.
Great. Well, thank you so much, Dr. Heysell, for sharing this information. I think, as you've mentioned, all of us sort of got a crash course during the COVID pandemic about how important it is to know about global health issues and infectious diseases. It's very important work that you are doing to improve the health of communities across the globe and here in Charlottesville. So I really want to thank you, and I appreciate you sharing your knowledge and expertise with UVA's alumni, friends, and families.
Well, thank you, and thank you all for listening.
Great. Thank you so much. And thank you to everybody for listening. For upcoming podcasts and other lifetime learning programming, recordings, and blogs, please visit our website at engagement.virginia.edu/learn. You can also find our podcast on the Virginia Audio Collective, which is a network of UVA podcasts hosted by WTJU Radio and can be found at virginiaaudio.org. So thanks again, and we look forward to taking part in future lifetime learning programs.